Hey guys, welcome back to the Foam Frat podcast. Tyler and Sam here. You'll notice that I'm outside, and that's not by choice. We've had a rough couple days here at Foam Frat. I came off of a 3-day stretch of working, and I came home every night, but you don't go down to the basement. I walked down to the basement, and it was all slushy, and the sewage had backed up, and the poor Foam Frat salt mines were soiled. So we are restoring the basement and the studio, so I'm outside right now. And then
My
we had some
studio
other
is great, man. In fact,
events.
I put one of those Glade plugins in here. It's smelling really good.
Don't even start with me. And then Sam started teaching a class and got sick and had to bail out of the class, 10 minutes into it?
Yeah, about that, man. I felt horrible. Yeah, was that Monday? I can't remember which day it was, but I woke up. You kind of feel like you didn't get good sleep, and then it turns out I was coming down sick. And man, we were starting that class. And I kept sipping water because, you get like the mouth sweats if you're feeling kind of nauseous. And as soon as the class started, like I hit the button to let everybody in. And then I was immediately thinking like, I'm just going to start talking. People start interacting. I'm going to forget about this nausea that I have. And then about 10 minutes in, I was like, hey guys, I'm going to run to the bathroom real quick. I'll be right back. And let's just say things didn't progress very well from there. So I tried to make it back as quick as I could to tell them that this probably isn't going to happen this morning. So I'm at 2 strikes with Brian King now. So.
Well, we wanted to get a podcast out before AMTC so that way we can tell you guys where we're at. Like, I don't know, like you wouldn't be able to find us, but we got a booth. I think this is our first booth we've ever done, like just Foam Frat, and we did it at AMTC. This is my first time actually being there. I realized I did actually speak at AMTC, but it was when they did like this ultrasound cocktail hour where I was just talking about ultrasound and drinking bourbon in the basement. And so I was like a guest speaker there, but that's during the pandemic. This is my first time actually going in person. So it's in Tampa, Florida, and we're going to be at booth 1204. And
Wow.
we got t-shirts and we got pens and we got reference cards and we got all the things you could imagine. So make sure you stop by. And we also have a really exciting announcement that'll be going out Sunday. We'll be doing a press release blog on it. And yeah, we can't wait to talk to you guys about that. So, unfortunately, old Sammy Claus isn't going to be able to make it. He's got somebody's got to be back. Yeah, somebody's got to be back to hold down the fort and steer the ship while Brian and I are out gallivanting. I just saw a bee come like flying up over here, and I can't believe it.
Oh, is this going to be one of these podcasts?
Yeah. Hey, Sam, just keep talking. I'll be right back. No, it's like 30-something degrees out here. What is a bee still doing out?
I don't know.
Well, so Sam, what are we talking about today?
Yeah, so we did that oxygenation clinic, and I wanted to follow through on a little bit of it. And one of the talks that I gave was called Through the Looking Glass, and it was about the different oxygen tension formulas. So everybody's familiar with the PF ratio and the Berlin criteria and stuff like that for just judging the difference between your PaO2 and your FiO2. It's super simple. It's like a Horowitz index you can look at. Oh, how bad is my patient's ARDS or whatever. But then there's these kind of there's these other ones that nobody talks about very much, and so I wanted to do a little bit of research on those and see how different they were, because you really don't. I mean, somebody starts talking about an A to A gradient and you're going through your head and you're like, that is an academic exercise through and through. And I won't contest the fact that A to A gradients and ratios, I think in most cases are kind of an academic exercise where you get more out of learning about them and how they work. It teaches you some great things about oxygenation and ventilation and stuff like that. So even if you guys don't ever think that you'll use it clinically, I still think that it's a good academic exercise. But I was able to find some good resources and go through and find out, like, why would you use one over the other? What are the pitfalls of each one of these? And it turns out it's like this Swiss cheese model. All of them have these gigantic holes in their reasoning as far as like PF, A to A ratio, gradient. Like they all have these big holes and things that they're missing, but it's like Swiss cheese. You line them up and you end up with less holes going through there. And it kind of helps with your whole holistic approach to oxygenation.
Yeah, traditionally, like the Berlin criteria, which is like the criteria we use for ARDS, has used the PF ratio. So it's looked at the PaO2 to FiO2 ratio. And I'll try to make sure that, like, as we bring things up, like, we actually spell it out, because you may have never even heard of that before.
Sure.
But the PF ratio is comparing how much oxygen is going in versus how much is actually making it into the blood. And so when you're looking at a PaO2, you're looking at the oxygen tension, the amount of oxygen just free floating in the plasma. This is not the oxygen that's bound to hemoglobin. It's just the O2 molecules that are inside the plasma. And you have to have a certain amount of pressure or tension within the vasculature, the pulmonary vasculature, in order for that to actually onload to the hemoglobin. And as soon as that value starts coming down, or that tension or pressure starts coming down, you're not going to bind as easily through something called like allosteric binding. And so when we're looking at the PaO2, this is the O2 that's made its way, in the mouth, down the airway, through the alveoli, and then actually through the capillaries or alveolar membrane, and then into those capillaries. And so that's a nice number to look at, because if somebody's got a bunch of boogers in their lungs, or they got, a pneumonia, a significant pulmonary shunting, you're going to be giving them a lot of oxygen through their mouth, but it's not all going to make it into their blood. And so you probably remember the formula to guess like what a PaO2 should be depending on how much oxygen you're giving somebody. So if somebody's on 100% oxygen, you times that by 5, and that's what their PaO2 should roughly be. So around 500 or so. And if it's a decimal, then, you times that by whatever, if it's 100. But when you are looking at that, one of the faults of the PF ratio is that, one, it's very hard to communicate from one ventilator strategy to another. You may have somebody come in and they have a PF ratio that's horrible, and the PF ratio is just the PaO2 divided by the FiO2. It may be really, really bad, and it may look like this patient's got ARDS. And then EMS comes in, they switch the patient to APRV, they prolong the I time, they start doing some recruitment maneuvers, and now they went from having severe ARDS to like mild ARDS, or maybe not, they don't even classify as like ARDS anymore. And that's an interesting dynamic, because then you're like defining the disease process by the person's ventilator knowledge, that's titrating the knobs and turning up the I time and playing with the PEEP. But where Sam, when we were talking about this, where Sam thinks like this AA gradient really shines is not so much the patient that you look and they got a PaO2 that's in the toilet and you got them on 100% FiO2, but it's like before that intubation phase. And so that's what I thought we could dive into a little bit, is where you would use that. You and I are walking into a hospital, they got a patient that is, that's that B again, he's coming by. We go walking into the hospital, and we got a patient that's not intubated yet, but we're like, I don't know, maybe they're on BiPAP, maybe they're on like a high flow cannula. How would you use that? Or maybe just the knowledge of knowing what that is.
Yeah. So a couple pitfalls with just looking at the PF ratio. So I shared an article in the blog that'll go along with this about, there are certain things that it's not very good at. So you're just using the FiO2 and the PaO2 that you get from your ABG. And so Deranged Physiology had this article, and I was going down all the pitfalls with them. And so here's the stuff, like let's say we go in there and we start looking at what their PF ratio is or whatever. Because you're right, like this, the first scenario we talked about before this podcast was like, okay, so like, we're going in and this patient's on 100% oxygen. They got like super crapped out lungs, maxed out ventilator strategies, and the PaO2 still sucks. That's not the area. You don't even really need a PF ratio for that. Like if you're on 100% oxygen and then your PaO2 is less than 100, I mean, you're automatic, whatever your PaO2 automatically is your PF ratio at that point, because you're just dividing by 1.0, which is your oxygen, So it's like, that doesn't take a big like guess to know what's going on. You're dealing with massive VQ mismatch, and that patient needs like maximum therapy. So that's not like the intricacies that like a ratio or gradient would go into. But check out this stuff. This is what they put together. And so the PF ratio doesn't account for, where is it? Not specific. So it's not specific to the cause of hypoxia. It doesn't take into account the PaCO2, which is actually important for like switching oxygen and CO2 over the AC membrane. If you have a chronic VQ mismatch, so like COPD or maybe interstitial lung disease, or you have a patient with hypoventilation atelectasis from like neuromuscular disease or from being bedbound for a long time or something like that, that totally screws it up. Doesn't account for any altitude. And an interesting point on there was that it was unreliable, whereas unreliable unless the FiO2 is over 50% or the PaO2 is underneath 100. So that's like a lot of criteria, and that's a lot of common stuff. Like how uncommon is it for somebody to have long-standing VQ mismatch, a screwed up PaCO2, and changes in altitude, and maybe if you guys are flying them or something like that. So there's a lot of things, but also if you look at the A to A gradient, which is, by the way, it's just the difference between the oxygen pressure in your alveoli and the blood, P big AO2 minus P little AO2. It's just a subtraction. And by the way, to get these numbers, I don't want anybody to, I don't want to go into the math with any of this kind of stuff, but you just need calculators. It's really simple. If you have your ABG, pretty much everything you need to get a PF ratio. What's that?
I said you want to go into the math a little bit.
I want to go into the math.
You're downgrading it
because you have to look at it. I'm not going to lie. I could do all podcasts on math, but if you have this A to A gradient, it's going to account for some of that stuff, but there's other things that aren't going to be measured as well. So like if you have a really high FiO2, the A to A gradient kind of gets screwed up. It is age dependent, which is good and bad, because as you get older, your lungs just don't transfer oxygen and CO2 back and forth as well. So that is kind of good. But that and the ratio are both kind of like non-specific when it comes to the form of hypoxia. So like you were getting to, you walk in and this patient's on, let's say, a high flow nasal cannula, or they're on some kind of BiPAP, and this is kind of a different patient, right? When you start doing transfers, like when I bring up this example in the blog about does EMS diagnose, and I bring up the examples of like you have a patient with a super low blood glucose, somebody with crushing chest pain, new ST elevation, a facial droop, onset 1 hour, like all these different things. And it's like, it's really easy in emergency care, pretty easy to be like, this is the overarching theme. And whether you're a paramedic or a nurse or an ER doctor, like your diagnosis probably just doesn't change very much. You're gonna do all very similar things. But in transfers, you're picking that patient up somewhere between they had this big overlying problem, respiratory failure for some reason, or whatever's wrong with them, and definitive critical care over here. And so you're not probably making these big sweeping changes. You're trying to figure out, like, where are you on this continuum of care, and what's the next most appropriate step that I could take to optimize this patient so that maybe they don't have to be intubated. How you doing there, buddy?
Just keep going, man. I'm just getting into it.
Yeah. This is really easy to watch. Hopefully they're watching the audio podcast or listening to the audio podcast.
I don't see what's so distracting over here. Just keep talking.
So yeah, this is like somewhere in between the middle where you are trying to decide, should we adjust the high flow settings, or does this patient need to go on to BiPAP next? Because where these indices can help you out a little bit. And I'm not going to sit here and say like, oh, if you just run the A to A gradient or ratio, like that'll make everything so clear. It really is like a holistic view of that patient where, yeah, you're looking at the ABG, the PF ratio. It's super easy to just throw these on. All you need is your end-tidal CO2 pretty much to run these formulas as well. Or I'm sorry, your PaCO2, not end-tidal CO2, to run these formulas as well. And then if you know what you're looking at, so like a low A to A ratio is bad because that means there's a low percent of oxygen going through from alveoli to blood. Or if the A to A ratio or gradient is really big, well, that would just mean that like you have a ton of oxygen in the alveoli, and why isn't it going over to the artery? And so when you look at those, and they're a little bit more sensitive for alveolar hypoventilation, which is a big one because there's always that swap that happens between oxygen and CO2 going in and out of the blood and the capillary, or in and out of the blood and the alveoli. They're more sensitive to that, where you would know like, okay, we had this patient with a bad PF ratio, we did some things, and now maybe undercover or uncovers a little bit of alveolar hypoventilation. So our ABG showed a little bit of respiratory acidosis. How much is that affecting like the pressure of oxygen that's in my alveoli? And so it's a little bit like I'll reference people or encourage them to go to the blog to look at some cases that I put in there. And the scenario is that like you're rounding in the ICU with a pulmonologist. They send you into a few different rooms to gather these values, and they want to know based on those values. It's like the ABG, all the indices that we've been talking about, plus scanning the lungs and the curve. And so it's like a bunch of stuff. But if you can kind of like picture that in a holistic approach, you can get a really good view of like what exactly is going on with that patient. And that's why I'm talking about like diagnosis is on that spectrum where it's not just this big sweeping change and this patient needs cardiac cath or this patient needs ECMO immediately. It's somewhere in the middle where you can use these to slightly guide treatment. But again, yeah, it's kind of a Swiss cheese model. You're always going to end up with some holes in there.
Yeah, there's a really cool app called AA Gradient that you can download. Was it free? Or I can't remember if it cost something, but I thought it was free.
I can't remember. It's a cool little animation, though. It could teach you even a little bit about it just by looking at their animation, though.
Yeah, can't you like change the thickness of the membrane to like change the VQ? I thought you could, but
Yeah.
I like it because it's more of a visualization thing, and like that's like even like Winner's correction when you're calculating like what your PaCO2 should be for a given bicarb. Like, yeah, that's important to understand, and maybe you're actually calculating that, but the fundamental, like the baseline of that is like, hey, this should be coming down while this is going up, or this should be going up while this is coming down. And I think those are really interesting because once you understand what an AA gradient is measuring, you really don't have to think about it as much because you get it. And so the way I think about it too is like, if you just had 100% oxygen going in, like you would say like, oh, well, my AA gradient, like my alveoli should be 100% full of oxygen, but there's always a degree, like you always have some CO2 coming off, so that's going to dilute some of that. And so that's what's cool about the AA gradient is it looks at your CO2, it looks at like the water vapor pressure, and you're actually looking at how much alveoli is in, or how much oxygen is in the alveoli before it makes that journey through the membrane. And that's something that you don't really get with a PF ratio because you're just looking at what's going in the ET tube or the mouth compared to what's getting into the blood.
Yeah, and when those A to A gradients and ratios and stuff are normal, so let's say you have a hypoxemic patient. I just want to recap those really quick, like PF ratio, PaO2, P little AO2 divided by your FiO2. So you're only looking at two big values, and that's why they're the most commonly used, super easy to do. A to A gradient, it's like the millimeter in mercury difference. So you have X amount in your alveoli, it's going down its concentration gradient into the P little AO2. So it's your like literal millimeters of mercury difference there between those two. And then your your A to A ratio, that's going to be looking at the percent of oxygen that's pretty much making it through. It's kind of similar to a PF ratio, but it's like a little bit more beefy because it includes like barometric pressure and it includes like, water vapor pressure. It includes PaCO2 changes and things like that. So just to kind of recap those, and you guys can look at, I have a bunch of illustrations in the blog that show you visually like what exactly that's measuring. And then the cases at the end are super helpful. But when you're trying to decide, like, okay, is this, the A to A gradient, oh, that's super sensitive to oxygen. But let's say you have like an A to A gradient that's normal. Patient's on a moderate amount of oxygen. They're not on maxed out settings. And let's say that A to A gradient comes back as pretty normal. And so does the A to A ratio, but your patient is still hypoxemic. Well, that would probably indicate to you that there's all these lists of things that go along with either an elevated A to A ratio or a normal or even depressed A to A ratio. And those will really start to show up when your PaCO2 gets high. And it can show you maybe how much of that alveolar hypoventilation is contributing to your patient being hypoxemic. And the reason that I threw the oxyhemoglobin desaturation curve into that blog in those cases as well is because that's what that's contributing to. That's like what that number is moving. And so I thought it was a nice little puzzle piece in between, like, okay, you can talk about the curve. Depending on how you explain it, it's either really simple or really complicated. And then you have like this PF ratio, but there's somewhere in the middle, like these gradients and stuff and these ratios, where it like shows you how those two numbers play into each other, and your acid or your ventilation, I guess I should say, and your oxygenation. It really like shows you what's driving that point on the curve, like one way or another. And I think it's really interesting as you learn more about how all these little puzzle pieces fit together. It makes the picture a lot more simple, because I think before I was really diving deep into these, I didn't realize that there was a little puzzle piece in my brain missing, and it kind of fit neatly into there in a very like chronological way. Like the oxygen comes in, what's going on at the membrane, how much of that is oxygenation, how much is ventilation, that's shifting the curve, that's affecting distal oxygen delivery. And so I don't know, I really enjoyed looking into them. And like I said, like I don't think this is something where you're going to go out and save the day by calculating a gradient or an A to A ratio or anything like that on your next call. But I think it's a great academic exercise. And I actually do think if you were comfortable enough with them, that when there are some sticky situations where you're trying to just figure out what is the next appropriate action without just like tubing this patient, I actually think it could help drive decision making.
Yeah, my typical workflow, like if I'm going in for somebody who's intubated, I'll just take like the intubated patient, and I'm walking in and, let's just say that they have an SpO2 of like 80 something percent, and they're cranking up the PEEP. They're already at 100% FiO2. Like the first thing is like, all right, can I trust like this SpO2? Because like if the pleth wave looks awful and there's like a blood pressure that's in the toilet, then obviously I can't really go off of that. So that's like my first mental thing is like, can I trust the SpO2? And then I'll try to get a gas. If they have not already gotten a gas, we can do a VBG or an ABG if they have an art line in. And whatever their PaO2 is, like we said, that's their PF ratio if they're on 100% oxygen. So then that really quick like gives me like a little mental of where they're at on the severity, because I can't remember off the top of my head, but I think it's like less than 300 is like mild, and then like less than 200 is moderate, and less than 100 is severe, something like that.
Use a calculator. So always use the calculator for everything.
I'll get an idea of like where they're at. And then like my next thing is like, what do their vent settings look like? Because sometimes you can have your PEEP so high that you're like tamponading off the capillaries, and you're creating your own shunt, but it's like an iatrogenic dead space because you've got that PEEP way too high, and it's like blanching those capillaries. And so if I walk in and the PEEP is like 15, I'm like, ugh. Like I have a whole blog called "You Rarely Need a PEEP Over 10," but sometimes you do, but like not a lot. So I'll look to see what the PEEP is. And then my eyes just naturally just want to go to like the eye time, because that's really where you get the most bang for your buck with recruitment. So I'll start turning up the eye time. If it's like 0.5, 0.8 or whatever, you need to get it up. You need to get like essentially like a 1-to-1 ratio, because sick lungs collapse very easily, or collapse probably isn't the best word, but they exhale pretty easily. So you got a really short like time constant. And so you don't need as much of an expiratory time. So I'll crank that eye time up, PEEP at least at 10, FiO2 is 100%, and then see what that does, and see where they get. And, I always used to say like, oh, you don't need a PEEP over 10, but then I had a burn patient last week and I needed a PEEP of like 15. So I was like, well, I guess sometimes you do need a PEEP over 10.
Well, the blog was rarely. And so,
yeah, you rarely need a PEEP over 10.
Yeah. Didn't say you never do. But yeah, and I think with patients like that, like the PF ratio is probably the way to go. It's a quick down and dirty number, but you might enact some of those ventilator settings, and you might increase the pressure and then realize maybe you don't need as much oxygen. So now your FiO2 is starting to come down because your PEEP is going up. You've recruited more lung. Maybe the patient is positioned differently and their compliance is a little bit better since you've overcome that surface tension of whatever's in their lungs, maybe pulmonary edema or whatever. And maybe now, their shunt isn't quite as bad. That might be the patient who's like not on maxed out therapy, where you would maybe depending on the numbers, be able to tell like if you did have a little bit of alveolar hypoventilation or if barometric pressure was playing a role in that patient not oxygenating very well, and you could fine tune it a little bit. But again, it's getting pretty into the weeds. I don't that crashing patient who needs care right now. I don't think that that's quite the patient where you would just see ridiculous numbers on all of those. Your PF ratio, like if you have a huge shunt, your A to A gradient is going to be through the roof. It's going to be like 600. Your A to A ratio is going to be like 10% of oxygen's making it through, and your PF ratio is going to be like garbage, you know, whatever the PaO2 is. And so it's just all going to look really horrible when you're on that much oxygen. But once you start backing up off those settings, it could help guide that therapy into like, what is the next step to, you know, I don't want to get too aggressive. I just want to make one change at a time. Maybe this can guide me a little bit. And again, it's not difficult to do. You really just need your PaCO2 from your ABG and technically the barometric pressure as well, which you can just get from like the weather app on your phone or whatever. So it takes a couple extra seconds. And if you know what those indices mean, it might impact your care. But it's definitely a good academic exercise. I think I got a lot out of studying these.
Awesome, man. Well, yeah, great blog post. This is all part of our oxygenation clinic that we did, and it's all recorded. We just got to get around to putting it actually inside a studio. So I don't know, man. I think that's it. You got anything else you want to throw in there?
No, I don't think so. I wish I could come with you guys down to AMTC. It didn't work out with my schedule, but make sure to, stop by that booth. I'm going to say the booth one more time. I have it in my notes somewhere. It's 1204. Yeah, so stop by booth 1204 to go see, get some swag with Brian and Tyler. And are you giving a talk there too or not?
I am, yeah, 2 talks, yeah.
Which one are you doing?
I'm doing one called the bee that's right next, or... I'm doing one on
and what else?
Man, I don't know why this guy keeps coming. Renal physiology, and then I'm doing one on the animated guide to ARDS as well.
I kind of just want to like keep asking you questions to see.
No, let's just wrap up this podcast, man. I should have sat like this the whole time. This is kind of nice.
Yeah, I like a little bit of the leg in there too.
Yeah, a little bit of the.
Next time.
What was I gonna say, dude? Oh, we're now I know, but now it's not as important as I built it up now. We're right next to the bathrooms. So if you're looking for the old foam frat booth and you don't know where the numbers are, just go to the restroom and we'll see you on your way out. We got some nice little clean wipes that we're gonna be handing out. To make sure that everybody stays nice and fresh, because we know how conferences. Yeah.
You never know what Brian.
We got those little CYA wipes.
Oh, okay. Very cool. Well, yeah. So stop by the booth, pick up some stuff. Stop by the bathroom and see foam frat.
We got some urinal cakes too that we're gonna toss in there. So. All right, we'll see you guys later.
Take care.
Dude, this bee